Respiratory embryology. The lung development occurs in 5 stages. It begins with the formation of lung bud from the distal end of respiratory diverticulum during week 4 of development. The mnemonic to remember the stages of lung development is every pulmonologist can see alveoli. So E for embryonic, P for pseudoglandular, C for canalicular, S for saccular, and A for alveolar. So let us see the stages. Embryonic stage is between 4 to 7 weeks, during which there is development of lung bud, then the trachea, then bronchial buds, main stem bronchi, secondary bronchi or the lobar bronchi, then the tertiary or the segmental bronchi. So errors at this stage can lead to tracheoesophageal fistula. Next stage is the pseudoglandular that lasts from week 5 to 17. So the structural development is endodermal tubules, then terminal bronchioles, which are surrounded by modest capillary network. So respiration is impossible and this stage is incompatible with life. Next stage is canalicular. Canalicular stage lasts from week 16 to 25. So the terminal bronchioles, then respiratory bronchioles and alveolar ducts surrounded by a prominent capillary network. Airways increase in diameter. The pneumocytes develop starting at week 20. Respiration is capable at week 25. Next stage is the saccular, that is week 24 to birth. So alveolar ducts differentiate into terminal sacs. The terminal sacs are separated by primary septate. In the next stage, that is alveolar stage, that is between week 36 to 8 years, the terminal sacs differentiate into adult alveoli due to secondary septation. In utero breathing occurs via aspiration and expulsion of amniotic fluid, and there is a high pulmonary vascular resistance through gestation. At birth, the air replaces fluid. There is a fall in pulmonary vascular resistance at birth. Choanal atresia. So blockage of the posterior nasal opening is called choanal atresia. It is often associated with bony abnormalities of the midface, most often unilateral. When bilateral, it represents an emergency and presents with upper airway obstruction, noisy breathing or cyanosis, and that worsens during feeding and improves with crying. Diagnosed by failure to pass the nasopharyngeal tube, and it is confirmed with CT scan. It is often a part of multiple malformation syndromes such as Charge syndrome. Charge, C for coloboma of the eye, H for heart defects, A for atresia of choanae, R restricted growth and development, G genitourinary defects, E ear defects. Next, the lung malformation. Pulmonary hypoplasia happens because of the poorly developed bronchial tree with abnormal histology. It is associated with congenital diaphragmatic hernia, usually left-sided, and bilateral renal agenesis, part of the Potter sequence. Bronchogenic cyst is a lung malformation which is caused due to abnormal budding of the foregut and dilation of the terminal or large bronchi. Discrete, round, sharply defined fluid-filled densities on X-ray, air-filled if infected. Generally asymptomatic but can drain poorly. There can be airway compression and recurrent respiratory infections. What are club cells? They are non-ciliated, low columnar or cuboidal with secretory granules. It is located in the bronchioles. Degrades toxins via cytochrome P450 and secretes. It is a secrete component of surfactant, and also the progenitor cells for club and ciliated cells. Now let us look at the alveolar cell types. Type 1 pneumocytes. They are squamous cells which are present in 97% of the alveolar surfaces, thinly lines the alveoli for optimal gas exchange. Pores of Kohn are the anatomical communications between the alveoli that allow for passing of air, fluid, phagocytes and bacteria in pneumonia. Type 2 pneumocytes, they are cuboidal and clustered. Functions are serves as a stem cell precursors for two cell types, both type 1 and type 2 pneumocytes. and proliferate during lung damage. They also secrete surfactant from lamellar bodies. Application of law of Laplace in alveoli. Alveoli have an increased tendency to collapse on expiration as the radius decreases. Surfactant decreases the alveolar surface tension, decreases alveolar collapse, decreases the lung recoil and increases compliance. Composed of multiple lecithins, mainly dipalmitoyl phosphatidylcholine. Synthesis begins approximately at 20 weeks of gestation and achieves mature levels at 35 weeks of gestation. Glucocorticoids are important for fetal surfactant synthesis and lung development. Collapsing pressure is equal to 2 into surface tension divided by radius. Alveolar macrophages. They phagocytose foreign materials, release cytokines and alveolar proteases. They are hemosiderin-laden macrophages, may also be found during pulmonary edema or in alveolar hemorrhage. So we are here seeing pictures of pneumocytes type 1 and type 2. Next comes the neonatal respiratory syndrome. So it happens when there is surfactant deficiency. So there is an increase in the surface tension which leads to alveolar collapse or ground glass appearance of the lung fields. Risk factors are prematurity, diabetes during pregnancy due to an increased fetal insulin, cesarean section delivery which causes decreased release of, there is a low release of fetal glucocorticoids and less stressful than vaginal delivery. Treatment is maternal glucocorticoids before birth and exogenous surfactant for the infant. And therapeutic supplemental oxygen can result in retinopathy of prematurity, intraventricular hemorrhage and bronchopulmonary dysplasia. So the mnemonic is RIB, retinopathy of prematurity, intraventricular hemorrhage and bronchopulmonary dysplasia for therapeutic supplemental oxygen. So screening tests for fetal lung maturity is lecithin and sphingomyelin ratio in the amniotic fluid. If it is more than 2, it is healthy. Less than 1.2 is predictive of NRDS, and foam stability index surfactant albumin ratio are also the screening tests for lung maturity. Persistently low oxygen tension can increase the risk of PDA. Coming to the next. So this concludes the embryology of the respiratory system.